All right. Well, good morning. Welcome. We are glad you're here today. I'm Sarah Hatch. I'm one of the social workers here at Sanders Brown. I'm joined by Regina Goodman from the Area Agency on Aging, Meredith Plant from the Alzheimer's Association, my other social. All right, is that better? Yes. Okay. Thank you. I'm sorry. No, you're good. A couple just housekeeping things. Do you know the restrooms are right here to the right in the center hallway? Feel free to get up anytime and use them if you need to. We will have breaks between the presentations, but just wanted you to know where those are at. This is recorded. After it's over, I will send out the PowerPoint presentations, any of the handouts that speakers talk about. And then once the recording is up and ready and posted, I'll send out an email letting you know where to find it on YouTube. So feel free, if you don't take all the notes, everything will be sent to you as well. But this morning we're excited to kick off. Dr. Jicha is here with us. He is going to share with us about dementia. Dr. Jicha.
Good. Well, hopefully that will work. Good morning, everyone. I'm delighted that you came today. I'm going to just kind of give an overview of dementia, some issues that you may all have questions about, and really it just sets the stage for today. And then hopefully we'll have time for questions and answers, but please feel free to interrupt me if something I say is not clear to everybody. So this is a big question that we get in general. What's the difference between Alzheimer's disease and dementia? And dementia really is something that we don't really diagnose. You diagnose that. You come in and tell us, my loved one is having impairments in their memory and thinking. That doesn't really tell us what the cause is. So it's really an umbrella term. The job of the doctor that you visit is really not to tell you that your loved one may have dementia, but it's to say, why do they have dementia? What's the medical problem that's causing that? Because only if we understand that can we actually try to help and do things in an organized fashion. So dementia, sometimes it feels like you're in this all alone, but it is incredibly common. And so this slide just shows the increasing prevalence with age. And some estimates are that by the time one reaches the age of 85, 50% of people will have dementia if we actually check them. Now, many don't come in to be evaluated, but that's quite common. So when I teach the medical students, I always tell them, if your grandparents come over for Thanksgiving and they're 85 years old, there's a pretty good chance that one or the other has a dementia. So age, number one risk factor for dementia. Now, why don't we diagnose everybody? Well, the patient usually is unaware of their symptoms. So everybody, I hear this all the time. They won't admit that they're having a problem. They can't admit it because they don't see the problem. People that forget that they forget. It's the rest of us that potentially are in denial. There's a lot of difficulties trying to raise this sometimes with healthcare professionals because the doctors, when they hear, oh my God, there could be a memory problem, they're thinking, oh my God, I got 10 minutes to spend with this person. I don't know about you guys, I'm seeing an executive health and I get about 10 minutes with my doctor. That's really what I get. So, so a lot of times the doctors are not real receptive to hearing that there's a problem. And then there's some cultural issues, a belief that memory loss and cognitive decline are just part of normal aging. And we see that all the time. And then widespread beliefs that forms of dementia are not treatable, and we'll talk about all that today. So this is kind of what the disease course is like for folks. And on the y-axis is a common memory scale that we use called the MMSE, the Mini Mental State Examination Score, from a 0 to a 30. 30 is doing great. You answered all the questions good. 0 is not so good. And so we'll see folks begin to develop some cognitive symptoms over time. And then after a delay, eventually we get a diagnosis. After we get a diagnosis, the disease will progress. We see a loss of functional independence where people need more help. We can see behavioral problems emerge. We can hit a point where they need 24-hour supervision. And that may be a nursing home or a memory care facility. It may be at home, depending on what your resources are. But this is really a time point of 24-hour care. And ultimately, after about 10 years on average, most folks will pass away, and this is highly variable. We have some folks that we followed for almost 3 decades that are still living at home and doing okay. We have other folks that can pass away within a year that quickly from onset of memory symptoms to death. But universally, these are diseases that eventually, until we have a cure, will eventually take someone's life unless they die of something else before then. Now, I always say memory loss is not such a good thing, but there are many absent-minded professors out there. I know many of them, and sometimes I'm an absent-minded professor. What it really is about is this. This is a loss of function over time. And so now we see on the x-axis the MMSE score from 25 to 0, and we can see as people progress, initially they may start having difficulty keeping appointments, using the telephone, and that will progress over time to having difficulty selecting one's own clothes or getting dressed. Eventually, even walking and eating can be impacted in the disease state. And so very, very important. So again, this is a big problem. This is graphs of the United States population in green, and the yellow wedge is 13% of the population over the age of 65. And if we blow that up, what we see is that about 13% of that population has dementia. 1 out of every 6 people, almost 6 million people right now, maybe even a little bit over on most recent estimates. So this is a big problem overall. Now, dementia can occur in much younger folks as well, but age is the #1 risk factor. And so typically we see folks much later in life. So one of the issues that has come up over time is that you don't develop dementia overnight. This is slow and it creeps up on you. You scratch your head and say, wait a minute, are we starting to develop a memory problem here? You just told me that story. And so somebody moves from normal to dementia, not overnight, but gradually over time. And so we also have a diagnosis that we call mild cognitive impairment. This is mild memory problems that a person can compensate for. They can use their GPS, they can use sticky notes on the refrigerator. And so we see it in that decline in cognition, and this is really where we want to catch the disease very early on. Because the sooner that we intervene, the better we're going to do over the long run. As that memory problem or other thinking problem persists, we'll start to see that impact on function, and that's really what signals a diagnosis of dementia ultimately. So now when we look at that graph of the United States, we can see people with memory problems related to a type of dementia is about 1 out of 3 folks over the age of 65. Very, very common. So you're not in this alone. This is a big problem. So this is really what my job is when people come to see me. There are many different causes for dementia, neurodegenerative conditions, and we'll touch base on the big 4, although I'll talk a lot about Alzheimer's disease today because it is the most common. But when folks come in with a memory problem, the first thing we do is we look under that umbrella at the other medical causes of dementia. Why might they be having memory problems? That's not a degenerative disease. And I do see many people like this, where I had several last week that came in that are just on so many darn medications that are impairing their memory that they actually need to come off their medicines. They don't have a degenerative disease. So we look for these things, and if we don't find them, then we start thinking about these. So really, really important. So how do you really know if a memory problem is coming up? Well, there are several different questions, and I use this. It's called the 88 screening tool. If you answer yes to 2 or more of these questions, there's a 95% chance that your loved one has MCI or dementia. So, and these are very simple questions. Does your family member have problems with judgment, problems making decisions, bad financial decisions, problems with thinking? And we always say that is a change from the past. I've always been horrible with financial decisions. I don't make them. I just give my paycheck to my wife and say, please do something good with this. So we're really looking for somebody who maybe was an accountant, did tax returns, and now all of a sudden can't balance their checkbook. Do they show less interest in hobbies and activities? It's not all about memory. This is sometimes the earliest sign that somebody's developing problems. Not showing up at church, not engaging in the things that they used to do, repeating the same things over and over again. This is a very important clue. Trouble learning how to use a tool, appliance, or gadget. Now, some of these newfangled telephones, I always give mine to my kids and say, show me how to work this. If somebody's been using the same TV remote for years and all of a sudden can't figure out how it works, that should be a clue. Forgetting the correct month or year, I always give people a little bit of leeway. If you're retired and you say, well, I don't know, it's Tuesday or Wednesday today, I know I'm not going to church, I'm okay with that. But when we have patients like I had yesterday, when I asked them what month it is and they tell me it's February, that's a big problem. It's not February. Trouble handling complicated financial affairs, balancing a checkbook. Again, if they've never done it, it doesn't count. But if it's a change from the past, trouble remembering appointments, general problems with memory or thinking. So these are just general questions that can help differentiate when a memory problem may just be normal aging, if your score is less than 2, or there may be a real memory problem if your score is greater than 2. So what else do we look at when we see folks in clinic? Well, we look for signs of depression and anxiety, and we'll talk about that. Sometimes I'll see folks who their memory problem is purely related to depression, and they don't have a neurodegenerative disease. They don't have Alzheimer's disease. But in all of the degenerative dementias, depression and anxiety are a common problem. We can see behavioral changes, sometimes inappropriate behaviors. Frontotemporal dementia is a form of dementia where behavior is often hit heavy, but Alzheimer's as well can cause behavioral change. We can see psychosis, hallucinations. And I'm fascinated with this. People have a tendency to see people and small animals. They may see other things, but typically they're visual hallucinations. And we see a lot of hallucinations in Lewy body disease, but we certainly see them in Alzheimer's as it progresses. We can see sleep disturbance, and this is really, really important. Sometimes, your loved one may want to sleep all day long, and you think, oh my God, this is great. I can get so much done. But then it should dawn on you, oh my God, they're going to be up all night, and that's going to be a problem for me. So these are real issues. And sometimes we'll see Parkinson's disease or Lou Gehrig's disease, ALS, begin to appear in the setting of a degenerative dementia. And these may be things that we need to treat and to help with. Very, very important. So When a person comes in to see me, typically we will test their memory. And this is one of our cute little tests. It's got little pictures of animals and the like. And what we're doing here is we're not just trying to test memory. So here's memory. We're trying to test all different areas of the brain to figure out what areas of the brain are functioning. So for a doctor, it's not so much, that the score is changing. It's where are we seeing new problems? Because that can help us to figure out what we need to do to help keep them doing their very, very best. So if somebody's having trouble with visual spatial function, they may need to stop driving very early in the disease course. Other folks, it's just memory and the streets haven't changed, may be able to drive much later in the disease course. So this is really, really important. Very few private practice or primary care docs have the time to even run these sorts of simple tests. There's much more sophisticated testing we can do. Most cases, we don't need it. So we also do a physical examination. And listen, frequently people will have vascular disease, hardening of the arteries, or little mini silent strokes. And so we want to listen to their heart and their arteries in their neck and look for other medical problems. Look for Parkinson's. These are all things that the doctor should do. So if you have a loved one that hasn't been to the doctor, hasn't been tested, hasn't had an exam, that hasn't been looked at for other causes of dementia, this is really, really critically important to do. And of course, the workup always includes a picture of the brain. And these are just some examples. Up here, we can see a normal control, and we've got a big, fluffy, plump brain here. And these areas right here are the memory areas of the brain. And you can see that they're starting to shrink here, the whole brain shrinking. This is where the spinal fluid is. It's starting to have a little more space up there, and the memory areas are shrinking. This is a sign for us that, this may be Alzheimer's disease, but we do look for other things. Is there a brain tumor? Believe it or not, we see this. Is there really too much spinal fluid? It's what we call NPH, normal pressure hydrocephalus. And it can look like Alzheimer's disease, but it's fixable by draining the fluid out of the brain. Vascular disease, little mini strokes here, and this hardening of the arteries, a big cortical stroke here. And in the different forms of dementia, we can often see different areas of the brain shrink differentially. So normally as we age, the brain shrinks like a balloon that you let air out of. All of our brains are shrinking. Unfortunately, that's just the nature of the aging process. But when we see specific areas, so here's somebody with frontotemporal dementia, their frontal lobes are shrinking and they're having a lot of behavioral problems. Another form of frontotemporal dementia, problems with language, we can see just this area is shrinking here. And people who are having trouble speaking, just this area is shrinking. So the MRI is used to both make sure we don't have tumors or strokes, but also to look at that imaging. Now, you won't see this typically on the radiology reports. The radiology reports typically will say mild age-related atrophy and small vessel ischemic changes. That's what they know, acute intracranial pathology. That's what they all say. It's like a template stamp. But a doctor who specializes in this area can derive a tremendous amount of information from these imaging studies. Now, there may be other things that we look at as well. So these are those memory areas of the brain on MRI, and they're shown in red here. Here's a 25-year-old. Unfortunately, here's a 75-year-old, normal in their memory and thinking. You can see already that those memory areas are shrinking. But if they have mild cognitive impairment, we see much more shrinkage. And if they have full-blown Alzheimer's, they've lost a lot of the nerve cells in these memory and thinking areas. Sometimes we may not see shrinkage, and we may send folks on for other imaging studies. Usually we can get all of this paid for by Medicare and Medicaid. It's usually not an issue. This is what we call an FDG PET. It's a radioactive sugar that we inject in somebody's vein, and then we take a picture of the brain and see where the sugar goes. And in a normal person, the brain lights up like a light bulb. As a matter of fact, your brain, anybody know how much a brain weighs?
6 pounds, isn't it?
All right.
6.
Yeah, about 2.5 pounds. Very tiny. Do you know how much of the body's sugar the brain consumes every day? 1/3 of it. Can you believe that? So if you guys had a donut this morning, do we have donuts? Bagels. If you had a donut, 1/3 of that is going right to your brain. In Alzheimer's disease, even before shrinkage, we can see the nerve cells not using that sugar. They're turning off. They're sick. They're not able to use that sugar and turn on appropriately. So sometimes we'll use this. And more recently, in the last decade and a half or so, we've had the ability to do what's called an amyloid PET scan, where we can actually look. We used to say you can only diagnose Alzheimer's disease at autopsy after somebody's died. That hasn't been true. It hasn't been true for about 27 years now, but we still cling to that anyway. This shows us, the amyloid imaging shows us exactly what a neuropathologist would see if they did an autopsy, but we don't need to take a person's brain out. We can send them to the scanner, and we'll see a patient with Alzheimer's disease with lots of plaques in the brain, and it'll light up. So this is Alzheimer's disease. We've also noted over time these HCs are human controls that some people who are still normal are already building up amyloid in their brain. 1 out of 3 people over the age of 65 who are normal in memory and thinking may already be heading down this path. We'll see. We're doing a lot of research on this currently to see if we can stop the disease at that point before it starts injuring nerve cells. But it just really points out to the scope of the problem. And this is just a description of what the pathology in the brain looks like, and it matches these cases. We can also do spinal fluid, and sometimes we need to do spinal fluid to rule out normal pressure hydrocephalus, to look for infections, other things of that nature. It's really not a horrible procedure. This is my back donating my spinal fluid for research many, many years ago. I one of my residents do it. He was scared to death that I was going to fail him out of the program. He did a good job. We actually can measure the Alzheimer proteins in spinal fluid very, very easily. And we're beginning to develop blood tests that you all may have heard about. The blood tests can be incredibly helpful for a quick look at folks. So there's going to be many issues that you guys are dealing with. Making sure your loved one gets an appropriate evaluation is important. There are also a lot of common behaviors that you're going to need to address. It's not just about short-term memory, but that lack of initiative. And we don't have really good medicines for that. I always tell people, if you're the caregiver of somebody with dementia, the best treatment for apathy or lack of initiative is a cheerleader. So break out your pom-poms. You got to grab them. Not, do you want to go take a walk in the park? Come on, we're going for a walk in the park. Emotional changes, mood swings, depression, agitation, anger, resistance to care, wandering, pacing. I want to go home, even when they're home. And it's very difficult, impossible to convince somebody who is in their own home and doesn't see it as their own home, that it's really their own home. You can't win an argument with somebody who's got a memory problem. Sometimes we just have to find other ways to deal with it. Hallucinations, changes in sleep patterns, rummaging, hoarding, loud verbal noises, yelling, abusive, combative behaviors. Always, I look back, I had two patients that came to visit me, a husband and a wife, and the husband had Alzheimer's and the wife had vascular dementia. And she was a collector of teddy bears. And so in the early stages of disease, she'd hop online on eBay and buy teddy bears. Every teddy bear she saw, she would buy. And her husband got jealous that she was getting presents and packages in the mail every day. And he liked Matchbox cars. So he began shopping for Matchbox cars. And the kids came over for Thanksgiving, and when they opened the garage was packed with teddy bears and Matchbox cars. Took the family almost 5 years to sell them all back on eBay. I don't know if they made a profit or not, but important. So a lot of what we deal with has to do with these psychiatric symptoms. And so this is a really nice figure from Medscape that I really like. This red line, the 0 time point, is when a diagnosis of dementia is made. And we can see that 3 years before dementia diagnosis, we see people starting to withdraw from their social activities. 2 years before a diagnosis, we see 50% of people starting to develop depression. That's big. And within 1 year of diagnosis, over 80% of people can be experiencing some degree of agitation. Makes it difficult to care for them at times. So why is this? Well, they're not behaving badly because they want to behave badly. It is that the disease affects this limbic system. And the limbic system controls memory, that's this little green structure, the hippocampus. But all of these other structures are for emotional control. And that's very, very important. So whenever we see a disease affecting memory, you can guarantee that that person is also going to have more difficulty controlling their emotions, suppressing depressive tendencies, suppressing abnormal behaviors or agitation. And so it's the disease, not the person. Very, very important. And these are problematic. They're what we call BPSD, behavioral and psychiatric symptoms of dementia. They account for 30% of the costs of caring for somebody with Alzheimer's disease. They're strongly associated with caregiver depression. So your depression, dealing with that consistently is a big problem. Strongly associated with, I just can't take care of them anymore. So they will undermine your ability to provide care. And so this is something that we really do need to work on, and it's a part of the disease. The first thing that we always think of when we see somebody who's having these sorts of behaviors is why? Frequently, it's not just trouble perceiving what's going on in the world and making sense of it, but also perceiving our internal signals. A patient with more advanced dementia may not be able to tell you that they're thirsty. Instead, they begin to get agitated. They may not be able to tell you that they're hungry. They may just be wandering around the house, not sure of what they're looking for, but all they need is a little food. They might be in pain. I have a patient that I saw just last week, and the family was asking about this. They say, yeah, she used to have intractable arthritic pain. And now she no longer complains of pain, but she's agitated all the time. And I said, why don't you go back and give her Tylenol on a regular basis that she took for her arthritis and see how that works. And she just called me yesterday and said, wow, she's doing great, much less agitated. So it was really pain, distress, feelings of abandonment. You know, this is a real problem. If you have a memory problem and you look around and your loved one's not there, you don't remember that they just stepped into the bathroom a minute ago, or have they been gone for 2 weeks? and they ran out on you. This can be really, really scary for folks. There are a lot of environmental factors, and we see this regularly. Sometimes I have folks come in and, 13 members of the family come in with them, and it's like a family reunion. If your family reunions are like mine, there's always an argument going on somewhere. A fight. This excessive stimulation is a real problem. You'll find that your loved ones with a memory and thinking problem will become emotional mirrors. If you're calm and peaceful, they'll be calm and peaceful. If you start getting flustered, they're going to get flustered. So sometimes reducing that stimulation, trying to keep to a daily structure and routine. We'll see a lot of times these behaviors only happen when that routine is disrupted. Inadequate lighting, confusing surroundings. This is especially important as we get closer to the holiday season, right? Rearranging all the furniture in your house for Christmas is not a good thing to do if somebody has a memory and thinking problem. Think about downsizing a cute little Christmas tree rather than moving the furniture and bringing in a monstrosity. Excessive demands as well. Realize that your loved one's not going to be able to perform at the same level that they might have in the past. So don't give them these tough tasks to do. You might need to downplay that as well. So when folks come in, and I see a lot of referrals for this, the first thing we do is take a history, and then we talk about environmental disturbances. Are there changes in the home? Saw somebody yesterday who's got flooded out of their riverfront home for the last time, and they're in the process of moving away from the river where they don't get flooded out anymore. And things are really disruptive for the family right now. And the patient is acting out for that reason. We do look for contributing medical problems, infections. We have a period of time, the first heat wave every year in May or June, our phones ring off the hook with people that are agitated or hallucinating, acting out, and almost always they're a little dehydrated and maybe have a urinary tract infection. And we can make it through that. They may not be able to tell us that, but we can figure it out. And then we look for drug effects as well, interactions, intoxication, withdrawal. I have a wonderful patient who was just the sweetest little thing. She's about 87 years old, and she did like her bourbon every night. And her daughter brought her over a bottle of bourbon, and they found her the next morning, the entire bottle gone. Mom on the floor. I hit her head on the coffee table going down. Alcohol and dementia don't mix real well because if you have a memory problem, you don't remember you've already had one. So you have another one and another one, and it's always your first, always your first. So we think about that as well. There are many over-the-counter medicines and prescription medicines that can create memory problems or these psychiatric symptoms, things that we don't think about. Medicines for heartburn, antihistamines like Benadryl. Benadryl is one of the biggies out there because they put it in almost every sleeping aid and allergy medicines. You can give somebody over the age of 65 who's completely cognitively normal enough Benadryl to make them hallucinate and appear to have dementia. So some of the others, obviously, opioids are problematic and the like, but this is where you need a doctor to review those medicines. So what do we try to do when we see these symptoms? Well, try to work on that environment, structured, secure, safe environment, maintain routines, distract and encourage constructive activities. Let's fold the laundry together, attend any medical or physical conditions. We need to support you all as well. And make sure that people are eating well and sleeping well. But always our rule of thumb is treat the dementia first. So again, distract and redirect, adjust the environment, structure consistency, limit overstimulation, and planned activities can be helpful. We always find as well your interaction. Remember, they're emotional mirrors. So speak clearly at a steady pace, keep the language simple. Eye contact, incredibly important. Be caring and warm. Address by name. Use nonverbal cues. I have a tendency to hold the hands of my patients frequently. That's very, very comforting to them. And you'll learn over time what the best way to interact with your loved one is. So we'll just review diagnosis. So this is really important. Again, any of you that have not had your loved one to a doctor for this, this is just critical. And this is, guidelines for all of medicine. People come in with a memory complaint or some other reason why they want to be evaluated. We'll do an examination and test their memory bedside in the exam room. If we need to, we can send them for more memory testing. Usually we don't. We'll do a medical workup, right? Looking for a few blood tests and a picture of the brain. And then we can usually establish a diagnosis of dementia or find one of these that we can fix. Then we define the type of dementia. We may need to use blood tests or PET scans or spinal fluid, but we'll figure out what kind of dementia it is. And then we can move on to treating the patient. Very important. So we'll shift gears from diagnosis and actually talk about the disease. So this is a picture of a brain from somebody who had Alzheimer's disease. There's a lot of shrinkage to the brain here. And Alzheimer himself, back in 1906, published the first paper where he showed these plaques in the brain. They're outside of the nerve cells. These are the little nerve cells. And these plaques are toxic to the nerve cells. They kill them. And on the inside of the nerve cells, as they get sick, they build up tangles. So plaques and tangles are the medical disease, the medical manifestations of Alzheimer's disease. So I do have a video here, and this will kind of describe what's happening in Alzheimer's disease. Oh, does that want to play sound? No, no one want to play sound for me today. Well, I'll talk you guys through it a little bit as we go.
By the German psychiatrist.
So there's Alzheimer himself. He has a monocle. I always thought I might get one of those when you're older. And this is the first patient, August D. She was in her early 50s. And these are the plaques
and
the tangles.
He reached the conclusion of a distinct disease
So
of the cerebral
Alzheimer's was the first one. She was actually in a psychiatric institution. And Alzheimer said, I don't think this is a psychiatric problem. She's got profound memory problems. And began to look at this. This is how our brain works. We've got all these nerve cells and they're sending electricity to each other so that they can communicate. They go through these little spaces, what we call the synapse, where they release chemicals. And the chemicals turn on the next nerve cell. So, as we see somebody with Alzheimer's building up these plaques, they're made out of what we call beta amyloid and neurofibrillary tangles made out of tau protein. We've really been trying to figure this out over time. And so, in all of our nerve cells, we have what's called APP, the amyloid precursor protein. And this is normally cut by enzymes and released, and it's cleared from the brain. But sometimes these little fragments, instead of being degraded and falling apart, if there's too much of them, they'll start clumping together. And as they clump together, they'll eventually form fibrils, which is like the little pieces of spaghetti, and that becomes what we call a senile plaque. So this is killing the nerve cells from the outside in. On the inside of the nerve cells, we've got a cell body and then that long wire, what we call the axon, where it sends its signal. And it's strengthened by what we call microtubules. These are like the beams and girders. And those microtubules are stabilized and made strong by tau. But in Alzheimer's, that tau falls off the microtubules. The microtubules start disintegrating, the beams and girders, and the tau starts clumping together to form tangles. So eventually what happens is all of those nerve cell connections start withering and dying, and the nerve cells can no longer communicate with one another. This is killing the nerve cell from the inside out. So plaques from the outside in, tangles from the inside out. Really important. I think we'll move on from this. I can. It won't let me. Very good. So that's the process of Alzheimer's disease. Sorry, I had to narrate that for you all. Now we get many questions about genetics as well. And if you talk to somebody who studies genetics, they're going to tell you it's all about genetics. Why? Because they want all of the funding from the National Institutes of Health. If you talk to somebody who's not a geneticist, they'll be a little more reasonable and they'll tell you it's about 50-50 genetic and environment. And this is really, really important. But true genetic Alzheimer's disease is incredibly rare. Incredibly rare. I only have one or two patients right now out of hundreds, if not thousands. This true genetic Alzheimer's tends to hit people very early in their 40s. And I even have one patient who's 27 right now, already with memory problems. And half of every generation will have Alzheimer's disease, all coming down in their 40s, at the latest early 50s. Most of us don't have that, but we still have some genetic risks. So there's a few things that we look at in terms of genetics, and classically we haven't pursued these, but they've become much, much more important. So there's one main genetic risk called ApoE. It's a protein involved with cholesterol trafficking. And I liken this to what I call the chubby gene. So that baby has the chubby gene. I have the chubby gene as well. I got it from my mom. Makes me want to carry around a few extra pounds. I don't have to carry around that weight. But if I don't watch myself, I do. And so here we can see squares are men. I don't know why men are squares and women are circles. And this is, a great grandpa who's got Alzheimer's disease and he carries the ApoE gene. And he passes that ApoE gene to a son who has the gene but never gets Alzheimer's. Passes the gene on to his daughter who gets the gene and gets Alzheimer's. She has a daughter who has the gene but never gets Alzheimer's, but she passes it on to a son who gets the gene and gets Alzheimer's. So it's not like witchcraft. It doesn't skip every other generation. But you can have the gene and get the disease, or you can not have the gene. You can get the gene and not get Alzheimer's, or you can not have the gene and you still get Alzheimer's. And it's really about 50-50. Typically we haven't looked at this, but some of the new medicines, it's very, very important, the ApoE genes, to gauge the risk of the new medicines that can remove amyloid from the brain. We'll talk about that a little bit later. So now, not everybody has Alzheimer's disease. Originally, right, people were just senile. And then we said, oh, it's all hardening of the arteries. And then in the 1980s, we said, no, it's all Alzheimer's disease. And we've gotten much, much smarter. So these are 5 different studies that really show that Alzheimer's is only about half of the dementia out there. There's also Lewy body disease and vascular dementia and frontotemporal dementia, among others. So really important. And they're different diseases. So at the microscopic level, we have plaques and tangles and shrinkage of the memory areas of the brain. In vascular dementia, we may have strokes and hardening of the arteries. In Lewy body disease, we have a different protein called alpha-synuclein, and that's building up in nerve cells. And in forms of frontotemporal dementia, we may have other pathology at the microscopic level affecting just the frontal lobes here. Very, very important. And so there are different criteria, and I won't go into those criteria, but doctors like myself need to know and understand these. And it's not always that simple. Frequently, we'll see somebody with Alzheimer's who also has some Lewy body disease or some Alzheimer's with some vascular dementia. So it really can be complex. But when we see people early on, we can look at these patterns, right? Is memory and thinking affected? Is language affected? Are there psychiatric symptoms, behavioral problems, or trouble with physical functioning? And all the diseases can look very different at the early stage of disease. But as the disease progresses, for all of these cases, eventually they will all look the same. So these diseases will spread throughout the entire brain. And in the late stages, the end stages of disease, there's pathology everywhere in the brain. So we need to be prepared for that as well. And what can we see? Well, we can see seizures and quite commonly. And typically they're not shaking and foaming at the mouth like we see in Hollywood movies. Typically they can just be blank staring spells, periods of confusion. And up to 40% of patients with Alzheimer's, if we measure their brainwave activity, will show us evidence for seizures. So quite common. We see bowel and bladder incontinence, and this is a real pain in the rear end. We can see folks start to not use their muscles, and they get stiff and contract. In the very end stages of disease, folks will assume a fetal position. And we don't try to stretch them back out and make them straight. That's very painful for them. We just kind of work with that. Folks will eventually forget how to walk. They'll become bedridden and eventually be unable to communicate for us. So what are we going to do? Well, we're going to try to treat people. This is important, and there's a lot that we can do. So this is an algorithm that I put together many years ago, and it basically shows kind of what I do when folks come into the office for follow-up. And we typically, the guidelines are about every 6 months. Some guidelines say you should see your doc every 3 months. Some say every year. Good compromise is about every 6 months. To reassess, because the brain is changing, and over a 6-month period, the brain may be very different from what it was 6 months ago. Some medicines that we needed before may need to be stopped, and medicines we never needed before may need to be started. So we talk about what's the major issue. Is it the memory and thinking? Is it the behavior? Is it the psychiatric issues? Is it motor impairment or physical activity? And we have treatments for all of these. But very important, we can only really do one thing at a time. We try to treat all all of these problems all at once, we're gonna have a mess on our hands. Because if they have a side effect, we're not gonna know what did what. So really, really important, slow and steady. Now, our dementia medicines are really come in two classes. These are symptomatic therapies. We have 3 approved cholinesterase inhibitors for Alzheimer's disease. And Aricept and Epizil, Exelon rivastigmine, which comes in a patch to avoid any kind of stomach upset, which is a common side effect of these medicines, and Razidine galantamine. And they're really equivalent. Sometimes we'll see folks, well, the donepezil's not working anymore because they're getting worse. So let's try something else. It doesn't really work. It's just disruptive to our patients. We have to trust there have been hundreds and hundreds of studies that have all shown the same thing. These medicines will slow the symptom progression, meaning somebody on these medicines is going to do much, much better over time than somebody not on these medicines. So very, very important. We do worry about stomach upset if we see nausea or diarrhea from turning on not just the brain, but the gut as well. We may try the patch. Sometimes if we give folks these medicines at night before bed, it turns on the brain. We may see very vivid, disturbing dreams. So sometimes we have to work with these medicines. Originally, they were approved just for mild to moderate Alzheimer's disease, and everybody thought that they didn't work in later stage disease. But now, 2 of them, donepezil and rivastigmine, both have FDA indications. Yes, they work all the way across the disease course. They always work anyway. And that's been helpful for us. Now we have a different class of medicines, and there's only one in this class, memantine or Namenda. And this helps not only with memory and thinking, but behavior and function, and can result in less time that you need to put in. If we have your loved one doing better, then it's easier to care for them. Reduces the cost of care. And this originally approved for moderate to severe Alzheimer's disease. And this is all just a pharmaceutical name. It works in mild disease as well. So we usually try to put people on both of these medicines. So here we are, we have a MOCA. This is another, that memory and thinking test with the cute little animals on it from 0 to 30. And we'll see somebody with Alzheimer's disease on this pathway if we don't treat them. If we treat them with a cholinesterase inhibitor, then we shift that curve. And if we treat them with both, we shift the curve even further. But you'll notice that we end up at the same place. These don't affect the plaques and tangles. All they do is keep the nerve cells functioning better than they would otherwise. So many people say, well, it's not going to make a difference in the long run. But if you look at this, would you rather have your loved one at the green dot, the yellow dot, or the red dot? I like the green dot. Green dot's good for me. Potentially delaying nursing home placement by 3 or more years. That's incredible. To me, that's incredible. So what about lifestyle modifications? Well, we're working on this, and many of you may have heard of the results of the Pointer study. What is that? Well, that's take care of medical problems, especially blood pressure. Keep the brain stimulated with cognitive activities. You don't have to go out and buy a computer program for hundreds of dollars. As a matter of fact, there's a very well-known computer brain training program out there, and they did a study and they compared it to a placebo treatment. And they didn't know what they were going to use for their placebo. They used crossword puzzles from the local newspaper. And the study was a failure. It showed that these expensive computer brain training programs are no better than crossword puzzles. As a matter of fact, crossword puzzles were actually better than the computer program. So it's important, whatever your loved one likes to do. And of course, increase physical activity. We like 20 minutes of walking every day. So diet and social activity also important. We don't really know how much, and be careful about social engagement. Larger crowds are going to be more confusing and may lead to agitation, disruption of routine. So yes, we want some social engagement, but we may need to keep it to smaller group sizes. Now, the field has also progressed. We know 95% of everything that we need to know to cure Alzheimer's disease. We just haven't cured it as of yet. We have been working not just how do we treat the symptoms, but how can we actually treat the disease itself. And so back in 1998, there was the first Alzheimer's vaccine was developed, and it was tested in humans. And it looked like it worked, but unfortunately, about 6% of people who received the vaccine died as a result of the vaccine. So that is true, and that's what happens with vaccines that are unsafe. They never make it to market. So that was unacceptable for us. Now, I always say, with that being said, most of my patients would say, geez, if I got a 94% chance you could cure me and a 6% you could kill me, I like those odds. Those are pretty good, better than what you get over at Red Mile or out at Keeneland. But we don't do things that way. So since about 2005, we've been working on passive immunization, and that is giving people antibodies against the Alzheimer plaques. And we can completely remove those plaques from the brain. And so over the last few years, what we have seen is 2 of those medicines receive full FDA approval. And we're treating people with those medicines currently. Very, very important. So lecanemab was the first one to be approved. We did back in 2011, we were running this study, which was what dose should we give? And this purple dose looked really good. An antibody every 2 weeks completely removes the amyloid plaques from the brain. And the phase 3 data showed that this will slow Alzheimer's by 30 to 40%. So it'll completely get rid of the amyloid plaques, but it still is not a cure. Now, what we have seen is if we get people who are mild cognitive impairment very early, the benefits are even much greater. And so we're actually testing right now with people who are cognitively normal. If we get rid of their amyloid before they develop memory problems, maybe it will cure them. We'll see. We still have to watch these medicines. The bottom pictures of the brain here, you can see this white. This is inflammation of the brain that can occur when we remove the amyloid too fast. It moves to the blood out of the plaques. The antibodies pull the plaques apart and drag the amyloid to the blood vessels. And then temporarily, if there's too much amyloid and we're removing it too fast, it will clog up those blood vessels. And that can lead to a buildup of fluid in the brain or even bleeding from some of those blood vessels. If we see that, most of the time, 99% of the time, we catch it with an MRI. We hold the infusions for a few weeks, let the brain come back to normal, and then restart again. Very, very important. But there are rare cases where we can see folks end up with devastating consequences of these medicines. So they're not to be used by everybody. And you'll find, as far as I know right now in Kentucky, there are only 2 clinics set up. Norton in Louisville has a clinic, and we have a clinic here. There may be a few other doctors out there that are using these medicines. So there have been many of them out there. Most of them have failed. But these antibodies attack the amyloid in different areas. And so we've come to realize that the ones that remove the amyloid from the brain best are the ones that help people the most. So getting rid of that amyloid is important. Now, some people have argued about, well, is slowing it down really all that helpful? But when we compare these, we usually will look at this and say, well, that's a 30% slowing. Is that good? But if we look at this timing here, say, oh my God, we might buy people an additional couple years before they decline. That can be incredibly important. So these medicines are not for everybody. They're only for people with MCI and mild dementia. When people get too advanced, they no longer will help at all. We have to send people for either spinal fluid or PET scans to get the Medicare and Medicaid approval. And then we do MRI scans for safety monitoring. We also check those ApoE genetics here, because the risk for developing these kinds of changes are much, much higher in people with 2 copies of the ApoE gene. And so we can actually tell people in advance your specific risks, not the general risks of the population. We can actually tell somebody your risk is X. And
Can I ask a question?
sure.
You ever heard of Osler-Weber's disease?
HHT,
What's that?
HHT.
HHD. I don't know off the top of my head. Is that human transthyretin?
It's your blood vessels break down and deteriorate, you bleed out inside normally.
Yeah. That's a systemic form of amyloid. It's a different, completely different disease.
Would you take that if you had it?
Would I take?
The infusion?
Right. Probably not. If I had a different form of amyloidosis.
So
It wouldn't
that
work.
is-
There's different, there are different medicines that have been approved for human transthyretin amyloidosis. There are completely different medicines for that kind of amyloid. This amyloid is the beta amyloid that forms plaques. It's very, very different. And so folks have to be able to get an MRI scan. I can't tell you the number of people that I see who have buckshot. I don't know, everybody in Kentucky has buckshot somewhere, I think. I send them to the plastic surgeons to get their buckshot removed. I had one person that had buckshot all over their chest. And I said, well, let's take a look. We actually did a CAT scan of the chest to look for metal. And he lived his whole life thinking he had a chest full of buckshot. And there's actually no buckshot at all. So I think we stripped him of some of his bravado. Anyway, he has that badge of courage, but anyway, he can get this. And we really need to use caution for people on blood thinners, because typically if the blood vessels bleed, they're what we call microhemorrhages. They're microscopic. And we see them and then we know, slow down a little bit. But if you're on a blood thinner, those bleeds could become very large and that could be devastating. So for other folks that may not be eligible for these medicines, I do want you to know there are a ton of other medications. We're not giving up. We continue to push. The medicines that we're developing today are far better. Our approved medicines were developed about 15, 16 years ago. And we've been treating people here with the recently approved medicine since 2011, 14 years before they were approved by the FDA. People already were receiving them here. So I do think it's worthwhile to take a look at these options as well. Research is not for everyone, but for many, it is an option to try to do more, and that's important. So let me stop there and answer any questions that you all have.
I have a question. So with that treatment, you must have evidence of amyloid plaques.
Yeah.
Do you see those in Lewy body and frontotemporal and cerebral vascular?
So some people with Lewy body disease can have amyloid as well. Usually we don't see amyloid in frontotemporal dementia. Frontotemporal dementias also tend to be a little younger in age,
Okay,
50s and 60s. And it's more likely for cases of frontotemporal dementia that it's pure frontotemporal dementia. Now, we are working on medicines for frontotemporal dementia, and we are working on medicines for Lewy body disease as well. But there's still a question. But the amyloid, the anti-amyloid medicines only work against amyloid. So if there's no amyloid in the brain, there's no risk to using the medicines, but they're not going to do any good.
is there any new treatment for cerebral vascular disease?
So we're working on that. We have several large grants from the NIH. We're part of several consortium that are working in that direction. Better biomarkers, better understanding of vascular dementia. There's been very little in terms of medications, but we hope in the next few years that we'll be expanding that, but not a lot currently. In England, they have a medication they've been using. Sometimes these guys are crazy. They take beetle cows' blood, and then they cook it to get all the protein out of it, strain it, and people go home and inject themselves with fetal calf's blood. The data is not all that convincing. It would never fly in the United States. But we have a few. Options. As a matter of fact, I'm just waiting right now for several of them. We need some final results before we push for some real large-scale clinical trials, because here in Kentucky we see vascular disease, hardening of the arteries, about as common as Alzheimer's disease. Really, quite common, or in conjunction. And that's one of the thoughts as to why the anti-amyloid therapies, why we can remove all of the plaques from the brain, but it only slows the disease. Well, we know we've still got the tangles there that we haven't done anything about it. And we likely have some degree of vascular disease. We may have some Lewy body disease. And so our data actually shows that only about a third, about 30% of Alzheimer's patients have pure Alzheimer's disease. 70% have more than Alzheimer's. They have what we call a mixed dementia. And we're going to have to target to eventually cure everyone. We're going to have medicines for all forms of dementia. We're going to have to be able to figure out exactly what each person has, how much of what, and then set them up with a personalized regimen. But we will get there.
A question about the blood thinners that don't work well with some of these treatments, is that right?
Yeah, so really only not things like aspirin or Plavix, those are perfectly fine. It's blood thinners like Coumadin or Apixaban, Eliquis, Xarelto, heparin, real blood thinners. So if you're on a blood, and many times there are ways that we can get people off of their blood thinners. There are new methods to treat atrial fibrillation that allows people to come off of their blood thinners. And so we pursue that with many folks as well that are looking at these medicines as an option.
So you're saying you cannot, if you're on blood thinners, you cannot have certain treatments.
It's, the FDA package label does not say that. It's not an absolute. And so, yes, do I have a few people that are on blood thinners, can't come off blood thinners that are on these treatments? Yes, I do. But they have sit down and have a real heart-to-heart with me over, whatever their potential risk is, 10% or higher is a 10% risk that you're gonna bleed and it's gonna kill you. And if they are, and so the few that I have on typically have said, I watched my mom or my dad, and I'm not doing that. I would rather die of a big brain bleed than I face my Alzheimer's disease. And if people, I'm really not here to tell people what to do. I'm here to educate them and ultimately allow everybody to make their own decision. We are in America.
So far.
So far. Do we have?
Question in the chat, yeah. What were the two medications that they find to be complementary and put people on?
So that is the cholinesterase inhibitors, donepezil, Aricept, rivastigmine, Exelon, Razidine, galantamine, and you just need to be on one of those three because they all do the same thing. And then the other medicine is memantine. So, and I typically am aggressive if my patients don't have side effects. I want them on everything. Because it's easier to preserve somebody's function than to try to bring it back after it's gone.
And then the other, oh, sorry, there's one more.
Yeah.
The other question is ibuprofen prohibited on TV? No.
No.
Thank you.
Great.
I was just gonna ask if the acetylcholinesterase inhibitors and memantine are okay or helpful for non-Alzheimer's disease. We don't really have a diagnosis for my mom and it's hepatic encephalopathy too, we're never gonna figure it out.
So the medicines are really non-specific. They really work to make nerve cells function better. And so we don't have many studies. Memantine originally was developed by Lilly in Indianapolis in the 60s, actually, as a drug to limit the size and disability from strokes and from traumatic brain injury. And then they lost interest in it in the 1970s and sold it to a company in Europe, and they jerked around with it, and it's good for vascular disease and traumatic brain injury. And then in 2004, they brought it back to the United States for Alzheimer's disease. But we really only have evidence for Alzheimer's, vascular dementia, and traumatic brain injury for memantine. The cholinesterase inhibitors seem to be more widespread. We've tested those actually even in people that are normal. And it makes us all think better.
Where in the diagnosis process would it be appropriate to ask for, if someone has been referred to neuropsych and you know it's going to be another year before they get testing and you get more information, can you ask for the treatment in the meanwhile?
Yeah, and then, that's a discussion to have with your doctor. I usually try to get people on these medicines right away.
Okay.
And then if we see side effects, then we stop. There can be exceptions to that, like the two folks that I saw that were on too many medicines that were causing their memory problems. I would not give them another medicine to treat their problem, which is too many medicines to begin with. So there might be considerations that come into play, but typically you don't have to wait for a definitive diagnosis. Sometimes the testing and the like. Again, it's rare for us to really need the memory and thinking testing. We're really looking more for what's the biological cause. If it's hepatic encephalopathy, then the liver dysfunction needs to be treated.
Right. It's all well controlled, so we just don't know what's going on.
Gotcha. So, and remember, these diseases are so common that often there is a lot of finger pointing. Well, it's just that I saw somebody just this Monday who's been looking for a diagnosis since 2017 when he started having memory problems. And originally they were told, well, I don't know. It'll declare itself if this is going to be a disease and a problem. And it just kept getting worse over years and years. So they went to another university and they were told, well, you have some mild memory problems, but we don't need to do anything for you. And kept getting worse and worse and worse. 7 years later, last year in 2024, they said, this is not helpful. And they went and visited another doctor, and the other doctor started them on memory medicines for the first time. That's 7-year delay. It's too much.
Right, there's all that loss that you.
And then they went up to the Cleveland Clinic, and at the Cleveland Clinic, they checked for amyloid, and he was amyloid positive, and he has Alzheimer's disease. So that's a shame. That's a travesty. Having a problem for 8 years. Now, I saw him on Monday. I'm already getting him started on a cholinesterase inhibitor over the next few weeks, and then he will start on memantine. I will bring him back in 8 weeks, and we will work him up for anti-amyloid therapy.
So if a neurologist has a new patient that they've seen once and they've referred them out to testing and they get a MyChart message saying, would it be possible to start these medications? They're not going to fire you as a patient for being pushy or anything.
No, I don't think so.
Okay, cool.
And if they don't respond to you, you can go ask a different doctor. Right? You can. Has anybody here ever fired the doctor before? I fired my doctor. The first doc I ever got when I came here to the University of Kentucky. She walked in the room. She looked at me and she said, "You're fat." I said, "Excuse me?" She said, "You need to lose weight. You're fat." I said, "You're fired." I got up and put my clothes on and walked out of the room. She said, "What?" I said, "You're fired." Always fire your doctor if you're not happy with them.
What about, is there any type of holistic medicines or things like that that would help?
So there are really nothing. You see a lot, in the news, and there's a multi-billion, if not trillion-dollar industry. All these supplements and things that you see in the stores. There's really very little evidence, almost no human evidence that those work. But in the laboratory, it may make sense that these are building blocks for brain health. A lot of that, nobody's ever really done the studies. And that's because it's hard to patent and make $1 million off of something the good Lord made. And so nobody's going to pay millions of dollars to run a clinical trial of a vitamin, because then they're going to have to charge an arm and a leg to recoup that loss. And the next company is going to sell the same vitamin, undercut them, and there's no profit in it. So a lot of this, I am fairly convinced that there's excellent evidence for fish oil for those that can take it. And there are some medicines as well that have been looked at otherwise in human studies, but not shown to have significant benefits. There's one that I'm really interested in. It's called the huperazine. It's a Chinese fern. And huperazine has been used for over 3,000 years by the Chinese to treat memory problems. Turns out when you analyze huperazine, it's got a cholinesterase inhibitor in it and another chemical that acts like memantine. So the Chinese actually were onto these medicines 3,000 years ago. Unfortunately, when we tried huperazine in Alzheimer's patients, we did not see positive results in that study. And it's probably that many of the herbal supplements are, they're not really controlled. As a matter of fact, there have been many exposés done that over 90% of the supplements that are sold in CVS and Walgreens and Kroger and everywhere else actually don't contain a single drop of what is on the label. They're not regulated by the FDA. You guys can go home and put sawdust in a capsule and sell it as Dr. Jicha's miracle brain formula. And if people will buy it, that's what happens. So unfortunately, there's a lot of work to be done in this area, but nobody will pay for it.
A couple questions. One is creatine.
Yeah.
They're saying that that's something that should be taken?
Creatine's very good for your muscles. It is conceptually very difficult. There are some early studies, some very small studies that suggest that, yeah, maybe this could help. The problem is nobody can figure that out because there are no muscles in the brain unless you're Arnold Schwarzenegger. And so nerve cells don't use creatine. So why would that? We think it's that it helps people increase their physical activity through its positive effects on muscles. So that's a big one. So yeah, I've seen these, and the media picks up on this. They picked up on this a little while ago. The folks that did that original study that generated the media interest have been trying to get somebody to fund a larger study, and it keeps getting shut down because there's no scientific plausibility to it. In general, maybe eventually they'll get funding and we'll look at it a little bit better, but.
Okay, and then back to Leqembi.
Yeah.
Have you experienced someone that's been on it and then stops? And does there a decline? Like your Rapid?
So there's a decline all the way through treatment with Leqembi. Again, if it's only slowing the disease by 30 to 40%, that means the disease is getting worse at 60 to 70% of what it would have gotten worse at typically. When you stop the Leqembi, there's a buildup of the amyloid. You don't lose the original benefits of it. You stay on that altered trajectory, but the amyloid will build back up again. Within about 5 to 8 years, it'll be back to where it was before. And that's why we've recently had approval after the 18-month treatment for Leqembi. Continued infusions at just 1 a month to keep it from building back up again. And more recently, the FDA approved home injectables. So after 18 months, people can give themselves a shot at home every week or so, like a diabetic would, and keep the amyloid from building back up again. That's been approved. It's not yet on the shelves. They have to ramp up their manufacturing of it. They say maybe late November, December, before that's actually available for patients as an option.
One more dumb question.
No
So your
questions.
body's all water.
No questions are done.
I've always complained her she didn't drink enough water.
Uh-huh.
Doesn't that help flush this? The more you can put through your system, doesn't that help flush this sort of thing?
So drinking water is a great thing to do, but no, there's no evidence that somebody's water consumption affects their Alzheimer's disease. But it's an interesting thought, and part of that is we have something called the blood-brain barrier. And the blood-brain barrier prevents the things that are in the brain from getting out into the blood that's what's been so problematic with coming up with blood tests for the disease, and prevents things that are in the blood from getting into the brain. So you can flush the blood regularly with water, but it's not going to affect the amount of amyloid in the brain.
I see.
Now, once the amyloid with these antibodies is pulled out, and I always find this fascinating, once the anti-amyloid therapies pull apart the plaques, bring them to the blood vessel wall, they take it through the blood vessel wall into the bloodstream. So it might be helpful for people to drink lots of water when they're getting anti-amyloid therapy, because eventually the amyloid winds up in your kidneys and you pee it out. So you literally pee out all of your Alzheimer plaques over an 18-month period, and you flush them down the toilet. And I always say that's where Alzheimer's belongs, flushed down the toilet. Did you have a question?
Kind of along that line of thought, but different. Have you ever looked into or heard of like oxygen therapy, or where people basically are breathing like pure like O2, or like there's also like Brown's gas.
So these are hyperbaric oxygen treatments, and you'll see a lot of for-profit clinics trying to sell that to people. There could be benefit, but again, they haven't done the studies, and that is always a little bit worrisome. Because one has to think, especially for hyperbaric oxygen, where it's a procedure, you have to have a hyperbaric oxygen chamber to charge for it.
Yeah.
So if they ran a study and proved that it was helpful, the hyperbaric oxygen makers would make tons more machines and would make billions and trillions of dollars. So why don't they do the study?
Yeah.
Why don't they? And many times you don't do the study if you don't think it's going to work. So right now, the only real indication for hyperbaric oxygen, there are two indications. One is deep sea divers that get the bends. Hyperbaric oxygen chambers are very good. And the other, we use it for gangrene. Did you guys know that? Some infections. There are some infections like gangrene that do not like oxygen. And so we put our patients in the hyperbaric chamber and pump that bacteria full of oxygen that it hates. And that makes it easier for the antibiotics to kill it and to treat and cure your gangrene, rather than just chop your limbs off piece by piece.
My dad has stage 4 kidney disease. Are any of those drugs compatible with that, or would they make it worse?
We have to reduce, depending on what the renal clearance is, what we call the GFR. We sometimes adjust the doses of the symptomatic medicines. And we would probably speak with, before we use an anti-amyloid therapy for somebody with severe kidney dysfunction, we would probably speak with their nephrologist to make sure that there are some forms of kidney disease that are actually caused by antibodies building up in the kidneys. And so we wouldn't want to give somebody like that more antibodies.
He's only got one kidney, so
Yeah. So, but for most of our folks, we don't even blink. Most of our older folks with kidney dysfunction that are not on dialysis are typically good for all of these medicines. So,
I have a maintain question. I was on it and it created unstable walking, so I don't take it now. I was wondering if I was able to be able to start it again, 5 milligrams one time a day.
Yeah.
Is a little bit better than none.
It's a very, very rare to have side effects from memantine. As a matter of fact, in the clinical trials, its a side effect profile was almost identical to the placebo, to the inactive sugar pill. But when we do see it, and it's very rare, about 1 out of every 100 people will see, like yourself, where it does cause balance difficulties and difficulties with their walking. And yes, that's typically the strategy that I'd use is 5 or 10 milligrams just once a day, and I would give it before bed when you're not up and walking, and not give a dose in the daytime. Again, if the medicines cause side effects, right? If somebody develops nausea and profuse diarrhea, keeping them on a cholinesterase inhibitor is not a good thing to do for their general health, right? They're not going to be able to socialize. They're not going to be able to go out for walks. It's going to be problematic. So sometimes we're limited by side effects to what we can do. And we do our best in those instances.
Okay, if I did take 5 milligram one time a day, could I expect, a difference, an improvement or what?
So sometimes people do respond to these medicines with improvement. But overall, the improvement is short-lived, they're symptomatic. And so the improvement is really seen by slowing symptom decline. That makes it very difficult with some of the symptomatic medicines to know if they're working or not. And frequently we do see that question comes up. And when people ask that question, I always say, I don't know, if you're not sure, and if it's, if you're not having side effects and the copay is reasonable, I usually say just stay on it. Because that's what the data shows. Sometimes if the copay is expensive or they're having side effects, I say, let's stop it and see what happens to your memory. And typically, if we remove donepezil or memantine from somebody that's on them, we'll see over the course of a few weeks a very abrupt decline. Or emergence of other symptoms, agitation getting worse because we've stopped it. And then we know, that wasn't a good thing to do, let's get them right back on it. But so sometimes we do have to test these medicines in an individual patient to find out what's best for the individual patient.
Thank you.
Great. So I should probably let you guys get on with everything else. Enjoy the rest of your day. Now you're going to get the good stuff.
All right, welcome back if you're online with us. We are going to continue on. We're going to move to communication and the importance of communication and some different strategies of communication. So we're excited to have Diane Vance here. I'm one of the volunteers with the Alzheimer's Association who's going to speak to us about communication.
Okay, I got to remember to stay here since we are also virtual. I was a high school teacher for too long and I got to wander around and keep an eye on everybody. My name is Diane Vance. I've been a volunteer with the Alzheimer's Association for about 10 years. I got my PhD a long time ago through Sanders Brown and did Alzheimer's research. Did not do that as a career, but I've been where you are because my husband got Lewy body dementia, which you heard Dr. Jicha mention. So I was a caregiver for him for about 5 years. So I've walked the talk, if you will. When I talk about this topic of communicating effectively, truly I can say that I sure wish I had known then some of the things that they talk about here. They were not intuitively obvious to me. So I will go through this a little bit quickly. I'm going to skip some of the videos. I'd rather have a little bit of extra time if you have a couple of comments or questions. And I always fight with this mouse about getting to this next thing here. This is an Alzheimer program. First thing they always do is tell you what it is we would like you to know when you leave here. So a little bit about how dementia affects communication, some strategies that you can use when you're communicating with people with dementia. And also something important, communicating with your family, friends, and healthcare professionals. A couple of words about that. That looks like a pretty obvious question, but remember that communication is not just for a teacher to get up in front of you and give information. Communication is also about how we tell people about our wants and needs, how we share our thoughts and feelings and ideas, and importantly, how we connect with each other. So keep all those things in mind about communication. And come on, I was a teacher. I'm gonna have a test. What's the correct answer?
All of the above.
Has anybody else been a teacher? A few people have. All right, you're giving me a lecture and I'm sitting in the back row. Communication? Oh, yeah, there's lots of ways we communicate besides just with words. That becomes really important in working with people who have dementia. You've already heard about this from Dr. Jicha. The only thing I'm going to point out here, when you're a caregiver and the person you're caring for has asked you the same question 15 times, do you ever get impatient? Nah. I always ask people, who in the group is a saint? And if you're not a saint, you're going to lose patience sometime. Maybe it helps a little bit to remember what Dr. Jicha said. It's killing the brain, and the person is not doing this to annoy you. The person is doing this because their brain is dying. It's not to annoy you. Some of the earliest signs that there can be dementia going on are related to communication. And you've already heard a little bit about this in Dr. Jicha's talk. I'm not going to read all this to you, but I bet you've experienced some of this. They don't communicate as much. They communicate more slowly, have difficulty in finding just the right word for things, so they make up some kind of funny words sometimes. Just lowered ability to communicate in general. Has everybody heard this phrase of a person-centered approach? If you haven't, this is kind of common when they talk about caregiving for anyone, but particularly for people with dementia. It might seem kind of obvious when I define it, but you want to know something about the person you're caring for. And guess what? You can do a better job of caring for them when you know something about that person, about their wants and likes and personality. So that's what they mean by a person-centered approach. One great example that I heard from somebody was, everybody in here probably knows what a wheat penny is. It's an old kind of penny that has a certain design on the back. Now, for most of us, if we began talking with you about wheat pennies, it would be kind of like, what? But one woman was telling me that her mom loved to collect wheat pennies. And even later in the disease, when somebody would bring her a wheat penny and talk about it, she would really get all animated again. That's I thought, a really great example of a person-centered approach. She knew something about what her mom liked. There are going to be 5 tips here that they give you about communication. The first one is really important. Treat them with respect and dignity. Sometimes as dementia progresses, we almost feel like we're caring for a toddler. And in some ways, you almost have to monitor like they are toddlers. Don't talk to them that way. Talk to them as though they are what they are, which is adults. So you don't want to also talk about them like they can't hear what you're saying or don't understand what you're saying. This possibly might occur if you go into a doctor's office with them. Have you had the experience that the doctor talks to you instead of to the person? That can happen sometimes. Don't do that. Don't do that in any setting, not just the doctor's office. This often happens in facilities too, where staff will talk about a person as though they have no comprehension of what's going on. Not a good thing to do. That last one is really important, those last two. You heard Dr. Jicha talk about hallucinations and delusions. Very common in Lewy body. I went through that a lot. Miss Scientist here, what did I do? No, you're really not seeing that cute puppy. No, there's no kids in the kitchen that need lunch. No, there's no bad guys in the house that are going to kill us. That was just what I should not have done. He was really seeing those things. Those were as real to him as you are to me. And what I needed to do was not argue or correct, but to try to think about what feelings is he experiencing and how can I respond to the feelings? And for the kids and puppies, it might have been, oh, aren't they cute? For the bad guys, he was scared. And what I needed to do was respond to that. And the same thing is true for all of their feelings. None of us likes to feel like we tell somebody something and they just kind of roll their eyes and blow us off. Nobody likes that. They might not know every word you're saying. They will understand your body language and your emotion long after they can hear any of your words and understand them. So I think that's a really important aspect of communication. The second tip about including them in conversations just picks up on what we just said. Don't pretend that they're not there, but they are slower to process things. So if you try to talk rapid fire to them or ask them a whole bunch of questions at once, it's probably not going to be very productive. What do you want for supper tonight? Do you want to have chicken or do you want to have beef? And would you like a baked potato? And did you see the TV show that was on last night? And isn't the weather? Slow, one thing at a time. You heard Dr. Jicha in that brief slide about communication. Engage them, make eye contact. It's really important to do that. Remember that question about, are you a saint? If you're not, this is one we got to really work hard on. We have to be patient. They will be slow to respond to us. Now, give them choices. How many?
Two.
Maybe two at the most. Don't give them a whole lot of choices. It's better if you don't give them any choices and just say, wouldn't chicken be good for supper tonight? You also heard Dr. Jicha talk about this one. If you need to talk with the person, don't do it in a situation where you've got lots of background noise or a lot of people or anything like that. He mentioned holiday gatherings in particular. They are having trouble processing what's going on around them. And the more there is going around them, the more difficult it's going to be for them to understand just the whole situation, and in particular, what you might be saying. simple. And for us older people, the last one about put away your phone, that one's not so hard. But I think for younger people, they're so used to the phone, they just do it and don't think too much about it.
Good question.
Yes.
So for limiting distractions, something that's come up in our house a lot is whether we can get her to wear hearing aids or not, because she feels overwhelmed when the hearing aids are in and confused. But then it's kind of hard to talk to her without them. How do you balance that, keeping them from being overstimulated and overwhelmed, but still needing to be able to talk to them?
My answer to that is unfortunately the answer to a lot of these caregiving questions. I don't know.
Okay.
Much of it depends on that person. Some people with hearing aids, it might not be an issue. Anybody have suggestions?
If she can turn the hearing aids down, I know I can. I've got my hearing aids up right now, but I can turn them down because it is really a problem
Okay.
if things are too loud.
Okay.
But that's about the only
So
thing.
you
I
have
can-
like an app on your phone?
Yeah, I do.
Okay, maybe
Yeah.
we'll get her some new ones.
You can actually do it from your hearing aid though. There are two buttons on the back and the bottom one lowers the volume.
Thank you.
It's just a possibility.
Yeah.
In dealing with so many of these problems, one of the most difficult things that I think about working with people with dementia, there's no one answer for everything. It would be great if you could describe a problem and we could say, oh, whenever that happens, you just do such and it's all taken care of. And you might take care of a problem and the approach works fine today. The same thing happens tomorrow. Got more. And I say that not to be discouraging, but to let you know that this is normally what happens and it's not just you that might be experiencing this kind of problem. And it's important to know we're not alone in this. We've already mentioned the importance of nonverbal communication. People do not have to say anything to you for you to know what they are thinking and feeling. And this is also going to be true even in the later stages. They will be able to understand if you're getting annoyed and angry with them. And sometimes during talks, I used to slam on the table and, make a big point of pretending to be angry. And I did that once, knocked over somebody's coffee and made a big mess. So I learned not to do that anymore. But if I had done that up here, can you feel the reaction you would have? It would be a visceral reaction. Somebody's angry, even though I might not have said a word about it. And I'm gonna skip that. This is another one of the test questions that I'm actually gonna skip of what's a good way for Alonzo to communicate with his wife. Which ones?
One. Pretty. She was a librarian.
Yeah.
So yes to this one and yes to that one. You've already mentioned the problem of distraction, no, don't turn the radio up really loud. Maybe if there's something the person likes on the radio, classical music, that might be a good thing to do, but it's a person-centered care. Meredith, is there a question?
Yeah, there's a question in the chat. I'll just read it verbatim. How about the whole apathy thing? My mom has a walker. I tell her we need to walk down a few houses and back so she can maintain getting out of bed, off the toilet, out of the recliner. She acts like I'm being cruel to mention walking. So obviously a communication issue there. So if you have any tips or anybody in the room.
First of all, I don't know that it's only a communication issue because Dr. Jicha mentioned in his talk, apathy is one of the most difficult things to deal with. There's no drugs to treat it. And his suggestion, the best thing you can do is not ask them about things, but almost say, well, it's time to go for a walk now. If they resist, this is another one of those questions that I don't know always what the best thing to do would be. Anybody else?
It might help to have a reason. So, hey, let's go up this way. I want to show you this pretty bush. Something like that, where it's goal oriented as opposed to just, something we have to do because we have to.
Having a dog helps.
Yes, having a dog, yeah. does help
For a
too.
walk.
And these last few slides. Communication is not only important for the person who has dementia, but for family, friends, and medical visits as well. One thing that can often happen is that the person with dementia becomes somewhat isolated because family and friends don't want to come and visit. Have you had this issue? And what I heard a lot was, oh, it makes me too sad. And I have to say, I didn't have much patience with that. Oh, isn't that too bad that it makes you sad? What about him? And if you explain to them that it doesn't really matter so much that you're having the same conversation over and over again, what the person will know is, hey, this person came to visit me, and this was nice to have somebody come and talk to me. Do I necessarily even know who they are? Maybe, maybe not. But they will know that a person is there who's spending time with them. So they say, how you doing? Oh, I'm fine, this and that has happened. And then 2 minutes later, well, how are you doing? And then they start asking you about people who died years ago. Don't correct. Just tell them that the person is doing well and maybe they'll come and see you sometime. But it really is important to encourage family and friends to keep on visiting that person. You probably already do this, but if you don't, it's helpful to the professionals, I think, to take notes and go in with the person. Because, has everybody heard of Showtime?
Yeah.
Well, if you haven't, here's a person with dementia, and I'm thinking of my husband here, and you take them either like to see family members they don't see very often, or you take them to the doctor, and guess what? By golly, they pull themselves together and they act just fine. And the doctor says later, what's the deal? They don't have any cognitive issues, or what? What's wrong with you, the caregiver, that you think my dad's got dementia? What's going on here? So don't be surprised if that kind of thing happens. And if you go in with them and you have some notes, it can really help the professional.
We've had that experience a lot, and I've gotten a lot of complaints from the person I'm caring for that I'm putting her under a microscope and embarrassing her in front of doctors by like saying things that have happened. And I haven't really, I've started just trying to get consent from her before we go in. Can I talk to them about this? Can I talk to them about this event? But then sometimes, if she's really agitated, I say less than I probably should.
And that's another tough situation. I wonder if it might be possible in some cases to talk with the physician separately.
I use the MyChart messages because then she doesn't really know how to get in and read them.
Or messaging, or even if you have written notes, a way to let the physician know that your perception is not theirs. You also remember Dr. Jicha said right at the start, they're not necessarily in denial about their condition. They don't even recognize that they have a problem.
I don't have a question, but I had a problem the other day because my daughter was talking to my spouse like she was 3 years old. You know, trying to explain something to her, and I was like, no, don't treat her like that, because then she gets upset and, you know. Anyway, that's the thing about it, communicating with family.
Yeah, yeah. Let them know the kinds of things that we've set up here. Don't talk to them like they're a toddler or treat them like they're a toddler.
I've got a question. My sister and niece live with my father. And they don't listen to me or my daughter who's an OT and has worked with patients in a hospital or nursing home. They try to argue with them. And I know they live with them and they deal with it a lot more than I do, but how do I make them understand if he says you didn't tell him something, just say, okay, I'm sorry, I forgot. But they argue with him and then he gets angry. And then my niece gets angry because she cannot handle it.
It spins things up.
It's just-
You know, I don't know what you do with people who won't listen to experts. For example, there's a brochure up here from the Alzheimer's Association about communications. And there's any number of places online where people who are experts in this will all tell you, don't argue.
I tried to get my sister to come. She couldn't get off work today, but I'm gonna send her all this stuff. Hope maybe she'll listen. I don't know.
Bring her communication brochure, bring things from the Alzheimer's Association or other places, because it will make things a lot worse.
Yeah, that's why I brought my daughter today. It's a number one, because she's so smart and she loves like,
Yeah,
showing that she's,
yeah.
yeah.
And just
Yeah.
the books that are on the table are free for you guys to take. They're a dignified life, so it's kind of talking about the best friend approach.
Yes.
But it is kind of helping a caregiver realize that that role changes. You're no longer the daughter or the spouse. At some point, you become like a best friend who's advocating and wants the best for their loved one. And so that book does a really good job sometimes helping the caregiver who's not quite making those connections that they have to change to. It helps kind of give them an insight into kind of what their loved one might be experiencing. So just
And I'm gonna stop at that point and try to get us a little bit back on schedule. I'll be around for a little while if you have other questions. Thank you.
So yes, we are the area agency on aging and independent living. Like I say, the other AAA, we're not the car people, but there's just really no easy way to say that. And so I am the caregiver program coordinator there and the dementia care specialist. And one of the things that we really like to reiterate with our caregivers, that it is very important for you to take care of yourselves first, so that you can be a better caregiver to your loved one. And I feel like that one of the best ways to do that is to come to things like this where you are learning about not only the disease, but resources that are, in your area that you can and should utilize. And so these are just some of the acronyms that we use. So the Kentucky Department of Aging and Independent Living, we call DAIL, and that is like the state level, the people at the state level are DAIL. We are located at the Bluegrass Area Development District building, and that's located at 699 Perimeter Drive. But under the Bluegrass Area Development District, we have aging services, community planning, workforce. So it's not just aging services in that building. We are all housed in that building, and the aging services is what's called the Area Agency on Aging and Independent Living. In that building, we also have the Aging and Disability Resource Center, and that is going to be the starting point for any of the services that we can provide. We do not provide direct care. So we are not a place that you go to for direct services. We are more of a referral and resource agency. We You are welcome to come to our building. We would suggest that you maybe make an appointment because we no longer have a receptionist due to COVID. Our receptionist retired, and so they have revamped that. And so we have to have, you can get into the lobby, but then you have to have a key fob to get into the interior offices. So it's best if you could schedule an appointment with someone if you would like to come up. We do have like an iPad kiosk in the lobby, but typically no one knows how to use that. I don't even know if I could use it if I was just walking in there to use that. And more often than not, we are caught, our restrooms are outside in the lobby. And that's typically what happens. People go to the restroom and someone will be standing out there and will say, can we help? But best case would be if you would like to speak to someone, just to schedule an appointment. And then a lot of our programs are funded through the Older Americans Act. Okay. And so we kind of just went through Area Agency on Aging, there are 15 located across the state. And so we are broken down into regions, and ours, here's our counties. These are our counties, the Bluegrass region. And then there are, like I said, 14 others across the state that will, that have their own designated. So I know we have people online, so if someone does not live in any of these counties in the Bluegrass region, maybe you live in Mount Sterling or Moorhead, that's going to be the Gateway region, we can get you linked up with those ADRCs in those counties. And we do offer a lot of the same programs. It could just be that they may be administered a little bit different. So all of the 15 area agencies on aging are going to have very similar programming. They just might they might look different in each county. And we'll go into that a little bit more. So these are just some of the services and programs that we provide. And we talked about the Aging and Disability Resource Center, which is the starting point for any of our programs, and we'll talk about that in a little bit more detail. But senior centers, nutrition program, home care, the nursing home, ombudsman, legal services, SHIP, health promotion and disease prevention programs. A lot of those programs are administered through the senior centers. The National Family Caregiver Support Program, that is the program that I'm the coordinator of, and I'll go into more detail about that. Medicaid waiver, the Kentucky Caregiver Program, which is, I'm also the coordinator of that helps grandparents who are raising their grandchildren. And we actually have two options for that. And then our Bluegrass Mental Health and Aging Coalition, that helps to put on an annual conference called Empowering Mindfulness. That usually happens in June. And then elder abuse prevention. So those are just some of the services and programs we talked about. So this is the ADRC number, the Aging and Disability Resource Center. So anyone can call me directly and I can talk to you about our programs. I can answer, the ins and outs of what the National Family Caregiver Support Program is. But in order to receive an application, everyone has to go through this Aging and Disability Resource Center. So this is a great number just to have. You can also email them. And what happens is when we refer you to that, you are just simply going to call and leave a message, a voicemail. And you're going to say your name, your contact information. If you hear something today that say, I'm calling about the caregiver program, or I'm interested in Medicaid waiver, or how do I get home delivered meals? So anything, you're just going to leave a brief message of what you're calling about. Now, once you have left that message, it's not necessary to keep calling back because that's going to go in a queue and they are going to answer those calls in the order that they are received. I think we have 7 ADRC specialists, and so they are just answering calls all day long. That's what they do. And so some calls may take a little bit longer than others. So, a few days may pass, maybe even a week, and you think, oh, are they gonna call me back? I promise you that they are. They are gonna call you back. So it's not necessary to keep calling. They will answer those calls in the order they are received. They will do the screening. If it's for the caregiver program, they're gonna screen you as the caregiver and your loved one as the care recipient. And then, you know, they may talk to you about other programs, like some of the programs that I mentioned before that we offer. And then they are gonna make those referrals for you. So just use my program, for instance, if they are referring you to my program, the National Family Caregiver Support, at that point, that's when you're gonna get your application, is after you have been screened. And so this is the elder nutrition program. So this is through the senior centers as well. They will screen you for those services. Determine your eligibility for that, for all of these. So this is the National Family Caregiver Support Program. This is a respite program that is funded through the Older Americans Act. And each year we determine the allocation. It's been the same amount for the last few years. It just will depend on the funding. But there's $2,100 per fiscal year. And our fiscal year goes from July 1st through June 30th. So we're just, you know, a few months into our fiscal year, and you would have still until June 30th to utilize that. And how that works is you have $2,100 that you could use for respite. And that is for someone to come in and stay with your loved one while you go to your own doctor's appointment, have lunch with a friend, you know, taking care of yourself piece, where you are just getting a little bit of relief from your caregiving. And the two ways that you can utilize that is either if you have a friend or family member that you trust to stay with your loved one in the home, then you can pay them. And then there's a little bit of paperwork involved, and then you submit that for reimbursement, and then we'll reimburse you for those for that amount. It's just a form that you fill out, and that's what we use for the reimbursement. We don't ask for copies of the checks or anything like that. There's just a form that you fill out and submit monthly. I do like to tell people that we are dealing with the state, so it is not a quick turnaround. It may be 6 to 8 weeks before you get that reimbursement back. And I just like to be upfront with people because, you know, we ask you to turn it in by the 3rd of the month. Like if you use it in September, we ask you to turn it in by the 3rd of October. But it's going to be several weeks beyond that before you get it. But unfortunately, we're just kind of at their mercy, and that's just the process. I wish there was a simpler process. So in addition, if reimbursement is not an option, you don't have anyone that can come and stay with your loved one in the home, then we contract, we put out for bid every 3 years for our respite provider agency. And currently it is Independence Assistance of the Bluegrass. They are located off Waller Avenue. So they have $2,100 for that amount. If you choose them, you will schedule with Independence Assistance. They will send their trained care assistant. They do a really good job of training their care assistants to come out, provide that respite, and then send us the bill. So if you use an agency, there's no out-of-pocket expense, and there's no additional paperwork with that. And the same we have $500 to use for supplemental supplies, which could be incontinence supplies, which I know sometimes insurances will provide the adult diapers, but they don't pay for the wipes, chucks, the gloves, some of those products that are necessary to use. So the $500 can be used towards that, towards Boost or Insure, and even some small medical equipment like a shower bench or grab bars and things like that. So that is $500. If, again, you can choose reimbursement, or you can order through Grogan's, which used to have a storefront here, but you can still order through them. Now, they only provide the incontinence supplies or the nutritional. They no longer carry the equipment. So if you would like to use an agency and you would like to use the $500 towards equipment, then we have an option of professional medical fulfillment. And that, between those agencies or the reimbursement, hopefully we'll be able to get you the supplies that you need. Okay. So you have to be, here's just some eligibility. The caregiver can be any age. You just have to be caring for someone 60 years of age or older or younger with a dementia diagnosis. And then we also, under the same umbrella of National Family Caregiver Support, we use a portion of our funding to help grandparents who are raising their grandchildren. And we do have both. We do have some who are caring for a loved one with dementia and then while also raising grandchildren. And so that portion of the program is we have $500 that the grandparent can use to purchase clothing, personal hygiene, school supplies, and bedding like sheets and pillows and blankets. If the child doesn't have a bed, like they've just been, emergency placed with them or whatever, and they don't even have a bed for them to sleep in, we can use the funding to provide for that as well. And that is one time per fiscal year assistance for that. And the Kentucky Caregiver Program, it is another grandparent program. So under the National Family, because it's funded through the Older Americans Act, the grandparent has to be 55 years of age or older. And we definitely have younger grandparents who are caring for their grandchildren. So under the Kentucky program, they can be any age, but they do have some income requirements that have to be met. But it is $500 per grandchild. So we do have several grandparents who are caring for multiple grandchildren. And so they receive $500 per grandchild under this program to purchase that. And we typically schedule shopping days at Walmart, and Hamburg is the one we typically use. And so the grandparent would go there, shop for those grandchildren, and then I show up, check them out, pay for it, and send them home. And so Medicaid waiver, this is a program that we get lots of questions about and inquiries about. Medicaid waiver participant directed services is how someone could possibly receive their services. You have to meet a nursing home level of care. And this, there's lots of parts and pieces to this applying for this program. And our ADRC, the number that I gave you, they can help you through that. They can help you apply for that. This is a little bit more difficult process than our program. With our program, you're going to call, they're going to give us your referral, then you're going to get an application in the mail from us within just a few days. This process, our ADRC specialists can walk you through that. You have to apply for Medicaid, you have to go to DCBS, there has to be a document from the doctor, but I'm not an expert in this process, but our Aging and Disability Resource Center specialists are, and they will walk you through that whole. And these are just some of the eligibility for waiver. And this is a way, like I said, that you can receive those services in home instead of in the nursing home. You can receive those in your own home. This is our state health insurance assistance program that helps with Medicare. If you have questions about Medicare, legal aid of the bluegrass, they can offer free civil legal advice, no assistance in criminal law. There are no income restrictions for this. So this is another one of the programs that we help with. And then this is a number if you need to report elder abuse. And so then health promotions, evidence-based programs. These are some of the programs, like I said, that are administered through the local senior centers. Drums Alive, that's a really popular one, and Bingo Size, a lot of people like that. And then, like I said, this is the committee that puts on the Empowering Mindfulness every year. And then home care program is a statewide program that it also provides for personal care in the home care. I think it's got some different services involved in that. And this is another one of those programs that our Aging and Disability Resource Center will screen you for. So when you call that and they actually call you back, the phone call may take a little while because they're going to be screening you for all of these different programs to make sure these are the services that are allowed under the home care services: homemaking, personal care, home delivered meals, respite, escort, which is accompaniment to the doctor, chore, and minor home repair. And that is, so we do have a Facebook page that they put all of our programs and things, any special events coming out, if you're on Facebook and would like to follow us on that. And then this is my direct contact information. That is my email and that is my direct phone number. So you are welcome to call me. Like I said, I'll be glad to answer any direct questions, but in order to get that application, you still have to go through the ADRC. I do want to talk about, so this is one of the things that we have coming up. We have partnered with the KIPTA Area Agency on Aging, and they serve more of the Louisville area, but some of their counties border our counties. And so about 3 years ago, we developed this health fair, and we have it at a Grafenberg Baptist Church, which is located in Waddy, Kentucky. But for folks living in, Franklin County, Shelbyville, some of those rural counties, if you come out to that, we're going to have, I think we have almost 30 vendors lined up right now. And then they're going to have vaccines that day and things like that. So it's if you live in that area or close to that area and you would like to join us for that, it is October 23rd. And like I said, you can get vaccines and lots of information. And I know that I just gave a lot of information to you. Does anybody have any questions? Yes.
Senior centers, I'm new to the area.
Yes.
Do you have a list of senior centers?
Okay, so also in front of you is there's going to be a green book called Pathways.
Oh, yeah.
That's another one of the things that we do at our agency. We put out this resource guide every year, and that's going to have all your senior centers located in that. And I don't know if you've ever been to the one here in Fayette County, but it is amazing. It is beautiful. They offer all kinds of programs. It's just wonderful. And so inside that Pathways guide, it's going to be resources for all of our 17. So not just for Fayette, but all the senior centers should all be listed.
And are they, you just show up or do you have?
You could just, I would just call them first and see kind of maybe what their process is. I know that Franklin County, they, there's like a check-in. I think you have like a Bob thing or whatever. All of them, they may all have a different process, but they would love to have you, and they, encourage people to come in and use. It's not like our grandparents' senior center. I think, I don't think it's like that anymore. I think they really, it's just it's a welcoming environment. They welcome people to come in and participate. And I know our senior centers, they go on trips, they go on cruises, and so they don't just sit in there and play cards. Like, they are out doing things and having fun. So I appreciate your time, and like I said, feel free to contact me directly if you have any questions.
Before we start with home safety, I know we're throwing a lot of information out, and I'm also going to throw a ton of information at you. So I just wanted to remind you that I will be sending out all of these PowerPoint slides. For those online, everybody here has a resource folder that has a lot of programs. It's got the information about all the different area agency on aging. It's got some upcoming programming. All of that will also be emailed out so that everybody has access to it. We've got a lot of upcoming programs on communication here at Sanders Brown. In February, we'll be doing one all about Medicaid waivers with the staff. That'll be virtual. We also have a lot of programs, just to highlight one that Meredith and I do together. Memory Cafe, which is a social not organization, but it's just a social time. So you can come bring a loved one together and we have fun. That's our entire goal. Because with all of these, we've talked about how much community is important, that interaction, that socialization. And that's the thing that becomes harder and harder with time. So Memory Cafe is a great program. And then we also have some highlighted support groups to help provide support. So I just kind of wanted to do a quick overview of all that so that when I'm done, if you guys need to leave, you get all the highlights. And if online you want one of the books that we talked about, Dignified Life, just put in the chat your name. We can either email me with your address and I can get it mailed to you as well. So we definitely don't want our online friends to feel left out. We can definitely get stuff to you. So with all that being said, we're gonna dive into home safety. And we realize that all of our goals are to create a safe environment for whoever lives in our home, no matter what. And so some things we do, no matter if our loved one has a diagnosis or not, we're trying to evaluate the environment, make sure things are safe inside and outside. We're gonna focus on how can we change things to make it work for the needs that our family has. When we're dealing with a dementia diagnosis, sometimes those adaptations have to be a little bit different. We have to adapt to them. We can't ask them to adapt to us. With all things, we need to be realistic when we're looking at home safety. There are some things we could do, but is it realistic? Is it cost effective? Is it time? Like, how long is it going to take? So we need to kind of think through all of those things. And then we need to be willing to reach out for help. Caregiving is not something that's done by yourself well. You need a team. You need a lot of resources. And so realizing when it's time to reach out is important too. This is a home safety checklist from the NIH. There are a lot of different checklists like this to kind of help guide you as you're looking through, what do I need in my bathroom? What are things I should be thinking about? So this is, one of those simple things just to reach out for a little bit of help. The Alzheimer's Association has another great checklist. Most of these are online and for free. It's just kind of a tool because sometimes our eyes don't always see some of the things because we're used to it, we've adapted. And so this is just kind of something to help cue us in. But when we're thinking about home safety and dementia, that's kind of what we're going to talk about today. There's three big areas that unfortunately dementia affects. So it's judgment and reasoning, sense of time and place, and physical abilities. And so again, our goal, we want to keep our loved ones safe in their environment. So with a dementia diagnosis, we need to kind of think through safety awareness because the dynamic changes with the disease as the disease progresses. So as a care partner, our safety awareness has to continue to increase. We are constantly having to reevaluate and think what our loved one needs and how we can make the adjustments. While our loved one, unfortunately, their safety awareness is decreasing. So things that they once always knew not to do, they might forget that you're not supposed to do that. So we could take away keys, we can have a conversation about driving, and they can understand and be at that point. But 6 months down the line, they may get keys and go get in the car because they don't remember having that conversation and being willing to give up the keys. And so we always have to kind of be on that lookout. And so that's when we talk about making plans of, making sure access for cars is taken away at a certain point that they can't get access because you just never know. So going into judgment, our ability to evaluate the situation and make an informed choice. So we know that that's going to change over time. So kind of some of the big areas of our home, our habits, hobbies, and personal care. I like pictures, so I have a lot of pictures in here to kind of talk through as examples. So in home, things like using a microwave. We think it can be easy, but do we remember that you can't put a spoon or silverware into the microwave? Do we think we're hitting something for 30 seconds and we hit the 3 and it's 3 minutes? Things like that can be affected. In the kitchen, leaving stoves on, burners can become an issue. Just kitchen tools in general. We've got knives and safety as a hobby, but if you love to cook, all of a sudden at some point, chopping up vegetables may not be the best thing. You might have to do an adaptation where now you're tearing lettuce or you're making some changes so it's still safe, but they can be involved. I put this in habits, but it's kind of with home, the garbage disposal is another big one. Something we do a lot of, it's our routine, but at some point we may not remember what it is. We start to look, oh, what's the switch? And it can be disastrous. So kind of thinking through little things like a garbage disposal that it's not usually on your radar, but you're having to navigate and make adaptations. Medications is another big one because we want everybody to be as independent as they can for as long as they can. But at some point, medications are going to become something you have to monitor to make sure that they're not taking their medications more than they should or not enough. Because when they're on blood pressure medicines or other types of medications, it's very important that they are consistent. But again, we want them to be as independent as they can for as long as they can. So it's learning that balance. Same thing with finances. And I have like the computer monitoring finances, another big safety issue. Early on, still able to do things. We want them to be independent. But we need to be looking out. Have they paid their gas bill 3 times this month? Or have they forgotten to pay their gas bill and now they're getting a disconnected notice? If they're online, are they still safely navigating online? Unfortunately, scams are at an all-time high through your cell phone, through your computer, and they're getting harder and harder to tell. I mean, there's been professionals here in the building that have been scammed by a telephone call. So it can happen to anybody, but especially if you have dementia of any kind, that judgment calls are getting worse and it's easier to give out a credit card information. You're not thinking through that process. So as a caregiver, being aware and alert and trying to help combat those things. Hobbies, another big conversation we have with families is about like power tools. Again, want them to be as independent as possible, but there are safety things you need to put in place. You can't go out into the shed to use your power tools unless there's somebody with you. And again, making sure maybe those are off limits at other times with the lock so that they don't wander in there to try to do something. And then personal care. Judgment comes into play a lot of times when do I need to change clothes? I don't need to change clothes. I just put these on. So kind of those things you'll start to see. Same thing with bathing. Here we have the hot and cold. These pictures, it's got a blue and a red. But a lot of times we see they get into the shower and they may not know which is hot, which is cold. So let's not take a shower because I don't know, So kind of things to just be mindful of. Physical abilities, you hear this a lot. This is mostly about fall risk. And then we'll talk through the senses real quickly too. So mobility is really about the fall risk, making sure we have clear pathways, making sure our home is well lit, stairways are clear of clutter. Ideally, there's 2 handrails on the stairs. And that you're wearing sturdy shoes or maybe non-slip socks because, some water might get spilled. You don't see it on the floor. We don't want them sliding off. They've got shoes, if your feet change over time. So if your shoes are kind of flopping around, it can also be kind of a tripping hazard. But there are a lot of devices that can help. So I have pictures of, grab bars like Regina talked about, raised toilet seats can be used. There's night lights that can be helpful to kind of guide. They've got some that can automatically come on as you walk by, but just well placement of some lights in the evening or at night can be helpful. When it comes to medical advice, reaching out for help, OTs, PTs, a lot of times can come into your home and do a home safety evaluation. This is usually something you need to talk to like your PCP about to get a prescription because it is a medical service. But they can come into the home and kind of help evaluate the bathroom. Where do you need to put grab bars? What type of device do you need to make the bathroom, the bedroom, a safe place for your loved one? Senses, we know that with neurocognitive diseases, it affects every part of how we interpret our world. So really through all of our senses, it's how we interpret the world, all of those are affected. So smell a lot of times can be kind of a safety filter. We don't think about it, but if we open the fridge and grab some food and it stinks, we're not going to eat it. But if that signal from our nose to our brain is not working or we just can't smell anymore, we don't know necessarily that that's gone bad. Same thing with things burning. A clue that something's burning, if we're not getting that signal, it can be an issue. So simplifying the environment. A lot of times with this, it's kind of using the items that you need in the area. So an example we'll see here in a minute is in the bathroom. Making sure that you're using stuff for bathroom. So toothbrush, toothpaste, we're not keeping the back rub lotion and some of those other things that maybe don't go into our body. We put them in a separate place. In the kitchen, some of those chemicals that we use for cleaning, we either make sure they're locked or we put them somewhere else so they don't accidentally get used for cooking. Just kind of a reminder, the disease with time, our processing slows down. So our hearing, from when we hear something to when our brain engages with it, the time between that increases. Same thing with sight. We might see something, but it may take us several seconds before we react. So being mindful of that. A couple more pictures. Fake fruit, especially this time of year, we see lots of pumpkins and gourds, apples. But we may not realize that they're fake. If we don't taste very well, we may take a bite. Magnets that look like fruit or food, a lot of times we've seen where people will pop them in their mouth and they end up choking. So it's being mindful of realizing that that judgment of that's a magnet, I don't need to eat it, can decrease. That just may look like a nice piece of candy. And then we talked about earlier kind of the distraction with the noises, multiple conversations going on, the overstimulation. A lot of times when those things happen, we'll see wandering. They're trying to get out to get under to a different environment. And so they might wander off, see where this door leads. And so that's kind of a time to be thinking through. So this was kind of the example I was telling you about. Toothpaste and this muscle rub look a lot alike. They're both in a tube, but you definitely don't want to brush your teeth with one of them. So that's kind of the way of just simplifying the environment. Our perception, the way we see things can change. So a lot of times what we'll notice is that with time, somebody on the floor, when the flooring changes, they may be really hesitant. Because if you look in that kind of basket weave pattern, it kind of looks like a basket. And I don't know if I would want to step on a basket if I don't know it's secure enough to walk on. The other one with the black holes, sometimes, again, doesn't make it look like it's secure enough for me to step. And so sometimes we'll see some behaviors that pop up based on that. Sometimes for safety, a black rug in front of a door can be enough of a diversion because they don't want to step into that black hole, not knowing where it's going to go. But being aware that the way we perceive things, and how we can adapt is important. Contrast becomes really important. So that's kind of the difference of having something behind the toilet so the toilet pops out versus when it's all white and it's hard to see. Everything kind of blurs together. We hear that a lot in the bathroom. Toilet's white, the wall is white, the bathtub's white, the walls around the bathtub are white. And it all just kind of becomes a big white blob. And it's hard to define where one thing is and where one thing is not. So sometimes with some color contrast can be really helpful. Being mindful of reflections, because sometimes it's hard to know where the window starts and where it ends. And then again, just contrast, these stairs would be very dangerous to walk down because it's very hard to see where the step ends. I'm going to the next one. But there are things to kind of help divert and adapt. So signs sometimes can be really helpful. Kind of a warning sign or a stop sign can be helpful. This is a sticker that goes over a door to disguise the door so it doesn't look like a door. It looks like a bookshelf to kind of help divert if wandering is an issue. Again, some more uses of signs, real life in a home. On the microwave, putting a stop sign. Stop doesn't mean you can't use it, but it might mean stop, wait. And depending on where you're at, you can even put signs that say stop, go find Joe. Or, can give some instructions. So signs can be really helpful. Sense of time and place is another big safety issue that we talk to families a lot about. This includes disorientation, wandering, getting lost, and driving safety. So when it comes to wandering and getting lost, technology is getting better and better. And so there's a lot of new tools that can help. So we always encourage, if your loved one likes to walk, or they have a tendency to get out of the house, making sure you have some kind of medical ID. The medical IDs can look very different these days. You can have a necklace, you can have a bracelet, you can order zip pulls that have all the information on them. Things that look like watches, like the options are getting larger and larger to fit what your loved one is comfortable with, because not everybody's comfortable wearing jewelry. There's things that can get put in your wallet, or their wallet to kind of, if they get lost, all your information is there. Things that can go on shoes like trackers. So if they're walking, kind of you have a way to track them. Cameras are another big thing that are being used from front doors to kind of help monitor who's coming to the door and who they're interacting with, to in the home, kind of getting a better idea. Some systems will allow you to talk. And if that's good and you guys like it, that's great. But also be mindful, your loved one may not like just a random voice coming out in the air saying, "Hey mom, what you doing?" That might scare them more than be helpful. Driving, another huge safety thing that we talk about. And like Dr. Jicha talked about early on, it's different for every individual. There's no one set timeline where you can say this is when you stop driving, because it is different. So questions that I encourage care partners to kind of look at and think about. Are they having trouble locating familiar places? Maybe they go to the grocery store every week, they always have, but now that trip's taking like 30 to 45 minutes longer. Why is that? Is it because they're making a couple of wrong turns? Or is there something else? But kind of something to kind of be alert to. Are they making slower or poorer decisions? And that's not necessarily in driving. You might see it in another area, but you might realize they're not able to make that decision quite as fast as they did before. That decision making might carry over into the driving. Have you noticed they're becoming more angry or confused when driving? Road rage. I talk to care partners all the time. They're like, I stopped at the stoplight, and they're very frustrated because I stopped, but I have to. So managing that. If you notice an increase in fender benders or hitting curbs, more dents in the car than normal, or all of a sudden they've had more tickets than before. Those are kind of warning signs to kind of look at and evaluate what's going on. Maybe this is a good time to talk about driving retirement. And maybe they are already realizing that driving's not the best option. So they may at night say, I don't want to drive anymore. I'm not going to drive at 5 o'clock down Nicholasville Road. I'm going to avoid that. They may start to limit themselves too. So it's learning to find a good balance that's safe for them and for those around them. And again, that kind of goes back to the safety awareness. Being aware that there are lots of tools when it comes to driving, because that is one of the big topics. The Alzheimer's Association has a great contract we can go through with your loved one and kind of talk about together making the choice to stop driving. There are driving evaluations that can be done by occupational therapists through Cardinal Hill, their occupational therapist program. They have a driving evaluation program that you can do. It is a little expensive. It's about $300 and insurance does not cover it. But it is an option out there that takes that decision away from you and puts it onto a professional. Same thing with doctors. Sometimes you talked about the struggle of talking in front of this, a big issue. So my chart becomes really helpful to like say to the doctor, hey, can you talk about this? Can you write a prescription? Because as soon as you leave that doctor's office, they're not going to remember the doctor said you can't drive. So sometimes asking the doctor for a prescription that you can stick on the refrigerator can be helpful. So there's a lot of different things to think about, but one of the big things is also managing your care. So home safety isn't just for your loved one, but it's for you as well. So it's making sure that you take advantage of the resources for respite, support groups, where you will find lots of tips and tricks. Because like Diane said, there's no one simple answer. You can do all the planning and all the safety things you think you can do, and there's still something might come up. So having that support group where you can go to and say, hey, I'm struggling with this, what are some ideas, can be really helpful. And there's some online support groups for those who work still. So there are different options to get support overall. Now I know I told you I was going to throw a lot at you really quick, but does anybody have any questions? Yes.
Do you have any advice for making it safer to be in a house that's 2 stories with bathrooms upstairs? Like the washing facilities upstairs?
So I mean, the handrails for sure. Lights, making sure ideally there's a light on top and bottom. And then it really just depends on their mobility and how well they're doing. And so at some point, if you're really seeing it struggle, that may be where you ask to see if like an OT can come in and kind of give some more tips of what can be helpful.
I'd say shoes too.
Yeah.
Like shoes on in the house?
Well, rubber, so that nothing that slides easily, if your stairs are carpeted or not.
They're carpeted, yeah.
And just trying to make sure there's that defined step A lot of times like carpet, you want to put tape on the carpet, but having a way to define each step can sometimes be helpful with the depth perception.
So like
as it
maybe like,
changes.
yeah, because she's said a few times about that perception.
Yeah.
Like,
I have one more question, I'm sorry. She just got a rollator and she's starting to trip because she can't see her feet anymore. Is there, I guess it's OT, probably Cardinal Hill or something, just talk to
I
them.
mean, they'll
about that.
probably have more professional answers to
Okay,
give.
sorry.
No, it's fine. And a lot of it's trial and error, trying to figure out what works best for her, how you can make the adaptions for her.
Okay.
I like to tell care partners a lot of times you become a detective because you have a problem, you have to figure out a solution for that problem, but it's that time. The next one, that same solution may not work and you got to figure out what's going on again. So it kind of is a never ending process, unfortunately, but hopefully we're starting to build your toolbox with different tools, tips, techniques to use in those different situations. All right, so y'all be quiet. I rushed through, so we finished like 2 minutes early. But feel free to stay around. Meredith, Regina, and I will all be here if you have questions. You should all have my email address. So if you have other questions or things, feel free to email me. I'm happy to email back, set the time to talk if need be. So thank you all for coming. We are glad you were able to make it.
Thank you.